Hello, everybody. We'll get started here in just a moment. We'll just let people trickle in and we'll get going here soon. Okay, welcome everybody. I'm Kiran Krishnan, and thank you for joining us for today's presentation on decoding fertility utilizing the in-depth urinary hormone metabolite test called the Dutch test. We are EndoAxis and are presenting this topic in partnership with Fullscript and Rupa Health. In addition, since the presentation is heavily focused on the Dutch test, we are excited to be joined by their Chief Medical Officer to support the Q&A portion of this talk. Now, EndoAxis was born out of a need to help clinicians turn complex hormone test data into clear, targeted solutions, thereby saving time, increasing confidence, and improving patient outcomes. Decoding fertility is a perfect application for this technology, and so we're very excited to be able to host this topic today. I'll introduce our speakers in the order in which they will present. So first, we have Dr. Liz Bartman from EndoAxis. Dr. Liz is a naturopathic doctor and currently serves as the Director of Clinical Science and Education at EndoAxis. Dr. Liz specializes in hormone optimization and aging with a focus on epigenetics and nutrigenomics. She's finalizing an advanced genetic certification from Stanford and has extensive experience in functional nutrition, bioidentical hormones, and mind-body medicine. Dr. Liz has also worked as a clinical educator for Precision Analytics, consulting on complex hormone cases and speaking on hormone health and environmental impact. Next, we have Dr. Jeff Glad presenting from Fullscript. Dr. Glad has been the Chief Medical Officer of Fullscript since 2019. Dr. Glad graduated from Indiana University School of Medicine in 2001 and went into family practice, but shifted focus towards health promoting care by completing the University of Arizona Integrative Medicine Fellowship Program under the direction of Dr. Andrew Weil. In 2010, Dr. Glad opened Glad MD Integrative Medicine, blending his health promoting care with high access technology. In 2011, he created and launched the web's first nutrient depletion calculator called mytaven.com. With the success of both GladMD and MyTaven, Dr. Glad has become a sought-after speaker in his field, speaking at TEDx and being featured in a variety of industry publications. And then finally, we have Dr. Jacqueline Smeaton from Precision Analytics, who will be supporting the Q&A session. Dr. Smeaton is a Chief Medical Officer at Precision Analytics and a naturopathic physician focused on infertility, reproductive, and genitourinary health. In addition to her private practice, Hello Fertility, she is a prolific teacher in the field of reproductive endocrinology and hormones and has trained thousands of clinicians on her treatment methodology. Dr. Smeaton has extensive leadership experience in integrative medicine, including as a president of the American Association of Naturopathic Physicians, as an ambassador for the Academy of Integrative Health and Medicine, and as a board member of the Integrative Health Policy Consortium. So clearly, we have a very esteemed and experienced panel of speakers here this afternoon. One matter of housekeeping that's really important is to please put your questions in the Q&A box and that you see in front of the screen and not in the chat. In the chat, they tend to get lost. And we've dedicated time at the end today to answer your questions. And we really want to answer your questions, so please put them in the Q&A box on your screen. And on top of that, also note that everybody here who's listening to this live and seeing the presentation as a recorded presentation will get the full Q&A and recording. And in addition to that, we'll also get the PowerPoint presentation from today. So without further ado, I turn it over to Dr. Bartman.
Wonderful. Thank you so much. And thank you everyone for joining us this afternoon. I am super excited to present on fertility and really on the role that having a deeper understanding through not just serum markers, but also urinary metabolites can have on the understanding of the metabolic imbalances that can really drive not only hormone symptoms, but also that fertility outcome and fertility challenges. So this is a pretty big complex topic. I'm going to do as much as I can within this 30-minute time frame, but I'm going to go a little fast because there's so much I want to cover. Just to jump into fertility and infertility. Why are we talking about this today and why is it so important? Well, because 1 in 6 couples worldwide to date are experiencing infertility. This is a pretty significant impact, right? And when you think about the number of toxins that we're exposed to, you really start to see a trend. You start to see that reproductive health truly is environmental health. And if you look at like just the impact from the 1970s to today and the exponential rise in toxin exposure and compare that with fertility rates, and there's factors that we have to play, kind of tease out there, but they really do kind of follow this inverse curve where toxins go up and fertility outcomes decline. I also always tell my patients before we jump into any preconception care or fertility workup, it always takes 2 to tango. So making sure that when you're working with couples, you're talking about fertility, that you always have both partners on the same page and that they're ready to go and really optimize their health in the same way, because 1/3 of infertility cases really are truly just male factor infertility, whereas about 1/3 are female and another third, the remaining third, are mixed or just really unknown. So again, reproductive health is that environmental health. This was a little shocking, but really it was only 62 placentas that were tested. But there was a study when I was looking at the role that micro and nanoplastics play. And I think I really am going to be highlighting these in particular when it comes to environmental toxin exposure, because we're seeing the profound impact that these plastics really do have on our health. I mean, Medscape every week, I feel like, has another article looking at just how profound these nano and microplastics are on all types of health outcomes. But in particular, we're seeing nano and microplastics in the ovaries, in the testicles, and in the placenta. And what was really interesting about this study when I started to dive deeper into it, this was a study out of the University of Hawaii, and they were looking at 62 placentas in 2024. And they found micro and nanoplastics in every single one of the samples in fairly high levels. When you compare that, they actually had done a smaller survey of around 20 placentas in 2006. And although micro and nanoplastics were identified in all of those samples as well, the amount was profoundly exponential in that 2024 sample. So not only is it in all of our tissues, but it is like massively bioaccumulating. It's getting worse, right? So again, reproductive health, it is environmental medicine. And that's really my background, right? Is that epigenetic, genomic expression and how our environment impacts that. So why? Why does the environment impact fertility so much? Well, because our eggs are so sensitive, as are the sperm, to oxidative stress. And to put this into perspective, we know age plays a big role, right, with fertility outcomes. And this is under normal, healthy circumstances, right? We know that women in their 20s are going to have a chance, about a 18% chance of conceiving their next menstrual cycle, with all factors taken into place. So they're trying, they have a receptive partner, they're not using barrier methods, which I had actually had to explain to one patient, you can't get pregnant if you're using condoms. You never know where people are coming, when you see people. But a 25-year-old, right, has an 18% chance, whereas a woman in her 30s, 40s, and beyond, that drops to around 7%. And the rate of miscarriage goes up with age. So as we get older and women are choosing to have families later and later in life, this does become a challenge, right? This is something we have to factor in, that age really is, under normal, healthy, optimal circumstances, impacting our fertility outcomes. But again, the oxidative stress is the other big burden that we have to factor in. When you're thinking about our eggs, right? So a female-bodied individual will have all of the eggs in her ovaries in her second trimester of development in her mother's womb, right? So you as an individual were an egg in your mother's ovaries when she was still developing in your grandmother. This is why epigenetic factors are so profound and why it's so important that we think about the environment, we think about nutrition, and we think about preconception care to really enhance not just fertility outcomes, but the health of the baby and the health of our family lineage, right? Because we don't want to just have a baby, we want to have a healthy baby, and we want to have a healthy baby that can continue to propagate a healthy family line. And it really does start with that optimization of the environment. Now, women, we are born, female-bodied individuals, right? Born with 1 to 2 million eggs in our ovaries. But very few of these eggs will actually reach that secondary maturation process, right? So in the ovary, during that, time during conception or during, actual reproduction or development, and then during that first about 10 to 12 years of life, there's a lot of like factors within the ovarian tissue that's choosing which eggs are actually going to make it to puberty, right? So 1 to 2 million eggs at birth. By the time you reach puberty, you have about 300 to 500,000 eggs, right? So you just slash that in half. And then by the age of 37, you're down to 25,000. And this is under normal, healthy, optimal circumstances. So when you're thinking about like every month, there's 1,000 just little eggs that are choosing which one in the ovary. They have to go through this selection process saying, okay, which eggs are viable, which DNA is going to be appropriate to actually have a fertile outcome, right? You're going through this apoptosis and selection process to figure out which egg is going to rule them all for that cycle, right? You're selecting that one pristine egg. And then the process happens all over the next month, but you're losing a lot of eggs every month. And you're going to lose even more if you're undergoing oxidative stress. So long story short, right? This is why environmental medicine is so important. So when you're looking at the role that micro and nanoplastics play on reproductive health, you have to understand that, as your tissues, as these endocrine tissues are bioaccumulating these xenoestrogenic hormonal modulating toxins, you're getting more oxidative stress, you're getting more DNA damage, and you're going to be declining that viability of all of those oocytes at a faster rate. You're also going to be including air pollution. So outside of the micro and nanoplastic world, we have all the other toxins we're exposed to: molds, viruses, air pollution, cigarette smoke, water pollution, pesticides, personal care products. These are all wreaking havoc on DNA, on chromosomal stability, and on the ability to really produce optimal, healthy eggs. So once you have the diagnosis, or once you're working on fertility, you don't get that diagnosis of infertility until you've been trying to conceive for 6+ months for a female, for a couple, for a woman over the age of 35 that has not successfully had a baby, right, by that 6-month mark. And this goes into, you might have gotten pregnant but had multiple miscarriages. That's still in that 6-month window going to be concerning and want to warrant further evaluation for, well, why, right? Why is there this struggle? For women under the age of 35, it's a year of trying without successful pregnancy and live birth. But I would argue that preconception care and really workup can start at any time. It's just the kind of aggressiveness that you go through or the more advanced testing that you would utilize changes once that diagnosis is made. If you have a patient who does have a history of frequent miscarriage, autoimmune disorder, diabetes, or any endocrine condition like PCOS or endometriosis or prior pelvic surgery, you want to start that more advanced workup earlier. You don't have to wait that 6-month mark. But again, preconception care can really start at any time, and it should start. If we can catch our patients in their 20s before they even are thinking about a family, but no, at some point I do want to try. You can start looking at wellness parameters at that point and see, like, are there going to be any obstacles early on that we can start to address now to really optimize their success when and if they choose to have a family later in life. So these are all the factors that really do can contribute to infertility. And purple are going to be our female factor only, blue is going to be the male factor only, but black is going to be for both genders. I'm not going to go into this extensively. I do have some cases I'll share at the end that I think really impact like why some of these concerns really need to be addressed sooner than later, but I'm going to save those because I'm already going over time. I ramble a lot when I get nervous. I apologize. But sometimes when it comes to preconception care, starting with just education can be the most impactful. And I always like to share this graph with my patients, and I think it's an important reminder for all providers when we're thinking about reproductive health. Like, what's going on with the menstrual cycle, and when do we need to test and why? And then how do we want to teach and train our patients on when is their preconception, when is their when is their optimal fertile window during their cycle? I cannot tell you the number of patients that come to me that say, oh yeah, we're definitely testing every month. I do my LH strips. As soon as I get a positive ovulation test, we have sex, right? And we have sex for 3 days after that or 5 days after that. And I'm like, well, at that point, you're too late, right? Your fertile window is actually 5 days before ovulation. And the reason is that sperm can actually live in the reproductive tissue for up to 5 days, right? And the age of the sperm is going to impact that duration, but it can live in that. It's going to travel and make its way through the uterine tissue or up through the uterus, through the fallopian tubes, up and meet, right, where that egg is going to release. The egg is only viable at ovulation once it ruptures for 12 to 24 hours. So it can only receive sperm for that limited amount of time. So once you ovulate, it's too late, right? You need the sperm there already. So I always talk to my patients about like track those ovulation kits or track your cervical mucus or track your basal body temp, but also make sure that you want to know kind of what is your ovulation date so that you can count backwards because your fertile window starts 5 days before ovulation. And it's also important to remember when you're testing as a provider, day 2 to 5 is the optimal time to see those peptide signals, to see that communication from pituitary to ovary. That's going to be the time when everything is at its baseline. Once you get past that day 4 to 5 of the menstrual cycle, LH and FSH start doing their own little dance, right? And the therapeutic impact of what they're doing throughout the month has less viability than it does on that baseline day. If there are spikes, if FSH or LH are too high or are too low on that day 3 testing, that's a problem. We know that we need to address that. So that's really why we want to get that baseline test. And I would argue that's really when you can just do all of your blood tests because you can see your thyroid well at that time. You can add in any other additional wellness parameters like a metabolic panel, a vitamin D, CBC, blood sugar assessment. This is a great time to just get the one poke, for the month. Whereas day 21, this is when progesterone surges, right? And the reason being that once that egg is ruptured out of the follicle, that follicle is now becoming a transient endocrine tissue called the corpus luteum, that yellow body. It's only viable for 10 to 14 days per month, but its primary role is to generate ample amounts of progesterone. So in that luteal phase, this is really when that endometrial tissue is beginning to develop a nice inviting womb, right? So estrogen starts to rise. It's like the little bricks lining the endometrial tissue and lining that uterine lining, right? Progesterone is the mortar that's holding all the bricks together. But once that corpus luteum rather, has reached its expiration, if you don't have HCG surging, you don't have an implanted blastocyst, then that corpus luteum is going to atrophy. It's going to become a corpus albicans. And that sudden loss of progesterone, your sudden cessation of that progesterone factory, right, causes the endometrial sloughing. This is also why if you have a progesterone deficiency, right, if you don't have enough mortar to hold all those bricks together, you can get that mid-cycle spotting. Things to watch for symptomatically. But this is a great time to test that estrogen progesterone ratio. And I would argue this is a great time to test that ratio in urine because you're going to see metabolically all the detox metabolites, the end products of all of those hormones that can tell us if there's a greater or a deeper dysfunction present that we might need to be aware of or address. So again, it's really important that we're educating our patients. Cervical mucus is actually one of the most accurate ways to determine that ovulation, that peak. But basal body temp can be used if you have a hypothyroid disorder. It may not be as accurate. LH strips can be used, but again, if you have PCOS, a little less accurate because it's always kind of high. And there's also Femtech on the market if patients want to engage in a more expensive way to track their cycles. They're pretty cool. They're getting more advanced. And then it's also important to remember that the male-bodied partner has to also be mindful of sperm capacitation. Sperm is maturing at about an every 64-day window, but it's going to be maturing rapid cycle every day, right? But it's that 64, so the sperm that you're ejaculating, right, had a 64-day maturation window. So it's really important that you're spending at least 2 months kind of optimizing both sperm and egg. In fact, the egg that you get pregnant with today really began its maturation process about 3 to 4 months ago. So whenever I talk preconception care, I ideally, under the best circumstances, would say about a year. But a lot of women are like, no, I want to get pregnant like tomorrow. So if I can get them to at least agree to 3 to 4 months, we're in a good place. We're at least going to optimize that next egg cycle, right? But for male-bodied individuals, we want to really optimize sperm. And so avoiding restriction to the testes, this is going to be extensive bike riding, tight pants, tight underwear. This can all have negative impacts on sperm, both count as well as its motility and morphology. Heat definitely plays a role on morphology, as do substances, of course. So then when we're thinking about what has to happen for implantation, right? How do we conceive? Well, like we mentioned, we have the rupture of a follicle and the release of an egg. And that egg is only viable for 12 to 24 hours. So we want that sperm at the ready. So did the sperm make it, right? Again, sperm can live in that reproductive tissue for up to 5 days. So you really do have a 5-day window where you can start to have sexual intercourse on a regular basis, and then 1 day after to really maximize impact and the probability that you will have sperm meeting egg at the right time. Once sperm meets egg, you get a zygote. And now that zygote is going to undergo a process called mitosis. And that takes about 3 to 4 days. Around day 4 to 5, that zygote is now becoming what's called a blastocyst. And a blastocyst is a kind of a cool accumulation of cells, and it has this layer called the trophoblastic layer. And this is a group of cells that allows that blastocyst to adhere to the endometrial tissue and to burrow. It literally burrows into endometrial tissue. And this is why some women will say they can actually feel when they conceive, because it can be like a sharp pain. But you have to have that blastocyst adhere and burrow, and then you get all of these great immune cells that come. And this is kind of like a expanded version of what's happening at that endometrial tissue layer. So we have that blastocyst, we have that trophoblastic layer, and that's now going to form into this placenta, right? So that's the beginning of that kind of burrowing, that nutritive layer that will then allow for those cells to start to produce our fetus. Now, when we're thinking about things that can go wrong, we have to think, okay, did they ovulate? Did sperm reach the egg? Is there an allergy to sperm? This is actually an interesting thing that women can have an allergy to their partner's sperm. And you can test this just like you can test seasonal allergies and pollens. And you can actually go through a desensitization process just like you can to your local pollens, to your partner's sperm if that is a problem. You also have to ask, well, do they have the nutrients necessary for that mitosis to occur? Do we have enough iron? Is vitamin D in balance? Do we have vitamin B12, folate, right? Are we nutritionally viable here? And then once that blastocyst forms, we have to ask, okay, is that endometrial tissue warm and inviting? Is there too much estrogen? Is the tissue too thick? Is there not enough estrogen? Is the tissue too thin? Is the progesterone too low to allow for that adherence and that development of that blastocyst to that endometrial tissue? Is there an immune response? Remember, the blastocyst is now a foreign body. It is now an accumulation of both mom and dad's DNA. So the immune system, mom's immune system, isn't going to recognize that as self. So if they are pro-inflamed, they could be attacking that blastocyst. That can be a problem. And at clotting errors, and I bring this one up because I think it's something that sometimes gets forgotten. Now, factor V Leiden, people are going to know if they are expressors of this condition, and they're going to need to be on anticoagulation therapy in order to conceive for women. But even carriers of factor II or factor V Leiden can be 20 to 30% more like in a hypercoagulable state, right? Which means any other factors, including nutrition, stress, or environment, can push them into being very coagulable, meaning that instead of adhering and getting nice nutrients and vascular flow to that blastocyst, instead you form a clot around it and it just falls off, right? You just lose that blastocyst that month. And I bring this up because, if this process is happening naturally, you're going to get that sperm meeting egg, right, in the fallopian tube. And then in the womb, this process of the blastocyst adhering, right, this can all happen under normal circumstances, but it also is happening in IVF. So with IVF, this process of sperm meeting egg happens in a test tube. But with IVF, they're actually transposing or transplanting, I should say, that zygote at around day 3. Because outside the body in a test tube, you might be able to get it to a blastocyst phase around day 5, but that is not as likely. So often they'll insert that zygote at day 3. So they'll do an implantation around day 3 and hope that once inserted into the uterine tissue or into the uterus, that sorry, my dog is whining in the background. I get really easily distracted here. I apologize. So again, with IVF, you have this zygote, it's being formed in a test tube. Around day 3 is when they tend to go through the implantation process. But the hope is that once inserted, it will form a blastocyst in the uterus and adhere and burrow. That doesn't always happen, and this is why IVF has a higher failure rate. They've found that if they can make it to day 5 and insert the blastocyst, there's actually higher conception rates. But again, that's not always viable. And specifically, it's the sperm. If the sperm is more oxidative or usually like of older age from an older partner, they really can't wait that 5 days. They find that day 3 is kind of when they have to do the procedure. And the other thing to note is when you're going through IVF, you're not inserting the blastocyst right into the endometrial tissue. You're just taking a pipette and inserting into the uterine space, right? So it's still has to bind, it still has to form its trophoblastic layer, it still has to bind, and it still has to burrow. So all the factors that are impacting this phase of implantation can impact both partners cycling naturally and partners cycling through IVF. And I just wanted to bring that up because I do get that question from time to time. So this is just an extensive list of questions you can start asking yourself, knowing that these things have to happen for implantation to occur. What might be impacting that process, right? So successful ovulation, we know that thyroid, mitochondrial, nutritional status, inflammation, environmental exposures, mold, autoimmune can all impact that successful ovulation. Whereas implantation can be impacted by STIs, scar tissue from especially chlamydia infections, inflammation, immune response, again, the factor 2, factor 5 carriers. Male-bodied individuals, we want to think STIs as well as varicoceles. Actually, one of the most common reasons for male factor infertility is a varicocele. Of course, their nutrition, their medication history, thyroid activity, vitamin D level for both genders as well, and then stress level for both plays a big impact. So you can start to see all of a sudden, if you were looking at a fertility panel, you would have theoretically a lot of options to run on this patient, and this could get quite expensive. But what if I were to tell you, you could just look at a few blood tests and look at some just functional peptide signals and responses for metabolic performance, and then understand the urinary metabolite process to really figure out, is there a deeper imbalance that could point us to one of these problems without having to go through extensive testing? And how might we do this? Well, we have to understand the journey that sex hormones have as they're being processed out of the body. And I'm not going to dive into this extensively, but remember, sex hormones, they are steroid hormones. They are fat. Fat does not play well with water. Blood is mostly water and protein, right? And so for us to circulate hormones, the sex hormones have to be protein bound for the most part. And then for them to get metabolized, they have to go through a series of steps that make them more and more hydrophilic. And this is going to be for estrogen well-defined through phase 1, 2, and 3 detox. I think about this as phase 1, sweeping up estrogen into 3 little piles. Phase 2 is taking those piles and putting them into garbage bags. And phase 3 is taking those garbage bags to the dump, quite literally. Here are enzymes involved in this process. I put in purple the primary players. We do have glutathione and glucuronidation happening as well, so I put those in blue. And in phase 3, we have beta glucuronidase. I think of those as the little rats that can come in and chew through and chew off that glucuronide side chain that's deactivated those estrogens and made them more hydrophilic so they can be eliminated out. And that little beta glucuronidase is saying, nope, we're going to cleave this off and allow that estrogen to just go right back into circulation. And this can impact estrogen excess symptoms, even if estrogens are not overtly elevated. But by looking at urinary metabolites, we can see trends that can tell us, yeah, this actually may be a problem. We may be recirculating more estrogen if we're seeing high estrone with lower metabolite clearance. If we're seeing higher 16-hydroxy metabolite, that can be a suggestive possible biliary sulfation and or GI issue. So there's little clues that we can start to look for. And again, I'm not going to dive deep into this because of time, but I think it's so fascinating when you're looking at these metabolites and you reverse engineer, if they're in urine, where did they have to come from? What enzymes were involved? And what are the factors that would either up or down regulate expression of all of those enzymes? And that is what EndoAxis does for you. It is saying, okay, if we're seeing high 4-hydroxy, for example, that means that CYP1B1 had higher expression. What can increase expression? Polyaromatic hydrocarbons, inflammation, and smoking. 4-hydroxy really isn't dangerous unless it's not methylated. So inhibitors of that methylation, if we're seeing low methyl ratios, that's lead, cadmium, coffee, alcohol, right? We can start looking at things like, okay, is environment a problem here? Is diet a problem here? The nutritional needs for these enzymes to express, do we need to maybe replace those nutrients? If 4-hydroxy is not methylated, it transforms into what's called a 3,4-estrone quinone. It's those quinones that go into the nucleus and create unstable DNA adducts. Well, what base pair of DNA is most subject to damage? It's guanine. And what else can you measure in urine? What do you get on a Dutch test? You get 8-hydroxydeoxyguanosine. This is a marker. It's like a little flag of all the damaged guanine base pairs in DNA. The higher your 8-OHDG, the more oxidative stress and burden there is at a cellular level. We can pull out those quinones safely through glutathione. Quinones are no longer subject to methylation, but glutathione can bind and reduce them to water. In urine, you can look at pyroglutamate. Are they too high? Are they too low? Do they have the right nutrients necessary for antioxidant support? DHEA, testosterone, progesterone, cortisol, they all go through their own phases of metabolism through the 5-alpha and beta reductase pathway, which is SRD5A family of enzymes. They're subject to 11-beta HSD, 3-beta HSD. So we have sulfation's a big one. So we have a lot of other pathways that we can start to tease out when we look at relationships, like with DHEAS. What is its ratio to its those metabolites, that androsterone and etiocholanolone, right? At a cellular level, what is happening between those ratios that could predict whether or not there's a lot or a low degree of inflammation? Are we seeing testosterone estrogen ratios that look a little skewed? Are we worried about CYP19A1? Again, is there that issue with 16-hydroxy with elevations in sulfated metabolites? And how can we start to piece this all together? You have the same with production and of course with cortisol. And again, I'm just blowing through these because of time. But this is like a whole world, right? You can start to really see how all of this metabolic and cellular activity is playing a role in how these metabolites get excreted and what we can make of that when we, again, reverse engineer and start putting those pieces together to say, okay, this is definitely someone who's got a lot of GI concern. Let's just treat their gut while we're working on their hormone balance, while we're working on that fertility journey. The other thing to remember is when we're looking at blood, we're getting a point in time. And that can be kind of misleading when we're looking at steroid hormones. So remember, progesterone's really the big one that's they're very pulsatile, right? Progesterone has a half-life of around 15 minutes. So it can actually vary 80% in 90 minutes, right? Which is huge. So the timing of your test, unless you're doing multiple tests throughout the day, you really don't know where they're averaging out with that progesterone. Estrogen can be impacted by FSH signaling, by cortisol. So there's a lot of variation with stressors throughout the day. And again, you don't know your average, you know a single point in time, and same with testosterone. So it's kind of a limited view versus again, in urine, you're getting all of those metabolites and you're getting that daily average, which really gives you the cellular utilization of those hormones. So I would argue that when you're considering preconception care, or you're considering kind of an early fertility workup, consider the serum test and add the urine for the day 21 to get more in-depth view of what's happening when that progesterone synthesis is at its peak. So this is just an overview of the basics that I would consider on day 3, the ideal LH and FSH ratio. I'm not going to go into great detail again because I'm running low on time, but you'll get these slides. So these are functional ideals. And again, this is coming actually from the works of Dr. Crinian and Pizzorno, as well as Doctors Ferguson and Weatherby, who are leaders in the functional space, both in environmental medicine as well as functional blood chemistry analysis. And I've really pulled out what they've defined as levels of certain markers that you're going to see on a metabolic panel, on a thyroid panel, a blood count, and glucose assessment that can tell us if there's something awry with the environment, or at a metabolic level, if there's something deeper we need to be concerned about. Even if they're in a normal range, right? Is there something that we can catch early before it becomes a problem? And again, you'll get these slides, so I'm not going to read through all of them. The one I didn't put on here, but I should have, is vitamin D, because vitamin D levels really are associated with fertility outcomes and should be assessed earlier than later, although insurance companies are not covering them like they used to, which is always a struggle. I also put on here vaginal health, and I'm not going to dive into this one as much today, but I did want to point out, especially for our IVF patients, so vaginal mucosa should really be limited in the number of, or the type, I guess, lots of number, but fewer in the diversity of the type of bacteria. So it really should be this lactobacillus, because it keeps the pH nice and low. And lactobacillus crispus is the one that's really shown to have highest probability for optimal fertility, right? And the gut biome also has links to fertility outcomes. But one thing that came up recently, and I just thought was really, I was like, this should be definitely something people consider, especially for IVF candidates. The lubrication used during well woman exams and during the IVF procedures, they contain chlorhexidine gluconate, which is a chemical that can actually knock out the lactobacillus species in the vaginal tissue for up to 2 weeks. So when we're thinking that, having this beautiful microflora in the vaginal tissue is correlated with better fertility outcomes, and then we're using this lubrication during IVF that knocks out all of that beneficial flora, that could be a problem, right? So possibly testing or just supporting our patients through this journey, supporting their vaginal health, may be really impactful as well to achieve better IVF outcomes. And again, day 21 would be your progesterone and estrogen value, because that's really when progesterone peaks. Or again, you can use the urine analysis and get a deeper insight. For men, one and the same. You don't have to worry about day 21. You can test at any time, but timing of the day is important. Hormones tend to peak in the morning, so when you're doing blood tests, AM samples are best. Or again, adding testosterone plus getting all those metabolites and cortisol, right? That's what you're getting with a Dutch Complete or a Dutch Plus. It's not just the hormone metabolites, but also the adrenal profile, which is so important for fertility. Now, when infertility is diagnosed, so now you have a couple who has been trying unsuccessfully for that 6+ months, or has a condition that would make infertility more likely, or make conception more of a challenge. You want to test some of these more advanced markers like anti-Müllerian hormone, which is really that marker of ovarian reserve. Prolactin can suppress and can go up functionally even under stress, but can suppress that ovulation, or that ability to ovulate. 17-hydroxyprogesterone is ordered if you have a concern for non-classic congenital adrenal hyperplasia, or late onset adrenal hyperplasia. This one actually has to be ordered before 8 a.m. for accuracy. So that one is a little caveat. You really do need an early morning sample for optimal results there. And again, if your urinary testing or history suggests that there could be high inflammation, you might be concerned about micronutrients, autoimmune, you could add more advanced tests. And these are some of those functional ideals there. And of course, when infertility is diagnosed, you need to do imaging. And so you start with a pelvic ultrasound, but depending on findings, you may have to go to that hysterosalpingogram to look for patency of the fallopian tubes, possibly even like diagnostic laparoscopy, which is really more for like our endometriosis patients, or if there is any concern or any abnormal HSG. And in male patients, again, don't forget, do a semen analysis, so important, because you can have defective sperm, and that's really going to make it a struggle, right, to reach the fallopian tube in time to meet with the egg. And that's something that you can really address with lifestyle and environmental and nutritional intervention. So again, with EndoAxis, you're getting that whole story. You upload your Dutch Complete or your Dutch Plus, you fill out some symptoms, and you get that personalized report, which is between 11 to around 20 pages, depending on how many findings are pulled out. But we really want this to be streamlined. We want to give you all the pieces of the puzzle so that you can then, knowing your patient and knowing their fertile journey, put those pieces together in a way that makes the most sense with their clinical presentation. You're also getting our help center. You're getting custom formulations. And I'm going to point out that all of our formulations are stored in glass. And not only is this really important just for the stability of the product, but there were actually some tests back to the nano and microplastic discussion. There's been assessments where even room temperature items stored in plastic for more than 6 months can get nanoplastic exposure. So when we think about all of our supplements and how they're stored, and even before they ever make it to the patient's home through the manufacturing process, we could limit their plastic exposure just by limiting the number of things we give them in plastic, which includes those supplement bottles. So we store everything in our product line in the glass for that reason. And hopefully, we're enhancing your patient outcomes by giving you those more thorough assessments. So I apologize for going so quickly, but I'm going to pass the baton over now to Dr. Jeff Glad to talk about how FullScript can help you integrate EndoAxis.
Awesome, Liz. Thank you so much. Most podcasts and webinars I listen to at like 1.5, 1.7. I feel like your content is so rich. I need to do this at like 0.2 or 3. So thanks for everybody for joining. I really just want to talk about really the seamless integration that has been built to really drive the workflow between EndoAxis and FullScript. If you're not familiar, both FullScript and EndoAxis are completely free platforms for you as a provider to use. And ultimately on the FullScript side, we're really committed to powering the provider that wants to deliver whole person care at scale. So that's creating an ongoing cycle of whole person care with the industry's best labs, like the Dutch test, high quality supplementation, like the ones developed by EndoAxis, and intuitive tools that drive personalization, adherence, and outcomes. We're also, really intentional about workflow efficiency and making sure that we can provide you with tools that allow you to practice, the full spectrum of whole person care, but do it in a way that fits your workflow. And I think you'll see here in the next couple slides how that works. So quickly, next slide is just a reminder, this is for healthcare practitioner education only. Next slide, Liz. So ultimately, the way this would work in terms of your workflow is you can use the FullScript platform or the Rupa platform, if that's what you currently use to order labs, to order the Dutch test for your patients. FullScript then takes that as an extension of you, works on educating the patient, getting them to get the kit sent to them. Once that testing is done, you'll see how things are happening. The kit was shipped, patient completed the test, test is in the lab. Once that result will then come up into FullScript, and you can take that PDF and upload it into EndoAxis. EndoAxis now, within a couple of minutes, day of, you're going to see that report. So you're going to receive that breakdown that Liz talked about in terms of the Dutch results through the EndoAxis report and really queuing that up. So once you get on the EndoAxis platform, sign up for your free account, you'll be asked to connect it to FullScript. And this will make the integration completely seamless. Next slide. Just kind of showing you what that looks like in the platform. So you see this is the Dutch Plus. You have the entire Dutch catalog to order from here. You would add that to the plan. Again, then gets sent to the patient to be able to purchase the test and get started in their testing. That PDF result then populates inside of FullScript, where you can review that yourself and then upload it into EndoAxis in the next slide. You're then going to see your report here, and you're going to see the full report. You're also going to see the supplement recommendations. I don't think Liz had the time to really dive into the elegance and the evidence behind the supplements that are being queued up in terms of the ingredients, the doses, the forms. It's all of the highest quality, purity, and potency, similar to the entire FullScript catalog. That's going to be easily able to be teed up for you. And I think in the next slide, you'll see how this then turns into a treatment plan. So the products will be populated. The dosing recommended on the label will be populated. This will all be queued up in your FullScript treatment plan to be able to easily send to your patient, whose name is also populated there already through this seamless integration. Next slide. So that's my end of it. I really want to get into Q&A and bring Jacqueline back in, again, who represents as Chief Medical Officer of Precision Analytical, who's really the the Dutch test founders, and really dive into some of the questions that you've had. We would probably just stop the slideshow. Oh, there we go.
Fabulous. Liz, do you want to join us back online too?
Yes, hopping back on. If I can get all my buttons to work.
So we had a couple questions come in. So I think, Liz, just a couple that come through around things that you covered. Someone asked around testing for allergy to sperm.
Yeah, it's the same way as you test for pollen allergies. So you actually do like a skin test, and you go to an allergist who is trained to do this, but they can take a semen sample and they do a little skin test with it. They purify it, they spin it down, and then they inject it under the skin just as you would like a PPD, or like a TB test, or a pollen test. And you look for that immune response. And so depending on the degree they rank it, like you're going to have a little irritation no matter what, because the immune system always is a little hyperactive to foreign bodies, but they can grade the circumference of the allergy, or the circle that forms around that.
Well, and just to add to that, when it comes to managing it, it doesn't mean that it's not treatable at all. And so what you'd really do is the same thing you'd do with if an allergy to a food. You limit exposure for a period of time before you're trying to conceive. So this is when barrier methods are helpful for fertility, is when you're trying to reduce exposure to semen if the semen is irritating. Or also they use IUI, where they'll wash the sperm and it gets transferred in like a non-seminal protein. It's usually not the sperm itself. It's normally the proteins in the semen. So there's some ways to work with that if that comes up. It's not super common in my experience, but it can happen. Okay. The next question is specifically on if a patient has prolactinoma and is on a prolactin reducing medication, bromocriptine or something similar, are there any special considerations that you would recommend?
On my end? Or
yeah.
Yeah, so I think it's all about, because number one, you have to get the prolactin down in order to provide that stimulation, right? For progesterone and prolactin are inverse. But I would want to monitor progesterone first and foremost. Are they synthesizing progesterone? Are they ovulating? And then in terms of med management and fertility, that's really one that I'm generally, when I see, I'm going to work on stress reduction. I'm going to work on the lifestyle and environmental factors, but I'm also going to be having them working with OB-GYN and with their fertility specialists and focused care members, because really my focus is around hormone optimization through lifestyle, through genetic and genomic expression and nutrition. I'm not as advanced on the infertility support. I always have my team of providers that I bring with me. So that would be one where I'd say I'd be wanting to manage with a team.
Great. Dr. Glad, this one is for you. Are there plans to integrate lab ordering from Charm through FullScript?
Yeah, it's a great question. And it really is a focus of the product team to build richer integrations inside of our EHRs. And so we've been working with all of our EHR partners to try to create more of, that elegant experience where lab results can move in. But I would also encourage you as a Charm user or any EHR for that matter to reach out to your EHR and request these integrations so that we have more people asking for this, which helps our cases.
Wonderful. The next question was really about Dutch, so I'm happy to answer this one. Like for the 21-day Dutch test, which test is recommended? Now we have kind of our two main tests, the Dutch Complete and the Dutch Plus. The Dutch Complete is urine only. The Dutch Plus adds 4 salivary samples, or 5. And so the only difference really between the two tests, the Dutch Plus is a little bit more expensive with the addition of the saliva, is that with salivary measurements, we utilize that for cortisol on the Dutch Plus test. And what it does is it allows us to add what we call a cortisol awakening response, which cannot be done in urine because urine is hours to process what's in our bloodstream out to the urine. And this is 3 time points, upon waking, 30 minutes after waking, 60 minutes after waking. And that cortisol awakening response has some interesting data on essentially like a resilience of the HPA axis. It's almost like a mini ACTH stimulation test. So it does have studies that correlate it to outcomes. So I would typically think about utilizing the Dutch Plus and investing in that if you think stress is a big component for your patient. Also, if they have a history of trauma, a history of chronic illness, history of glycemic dysregulation, anything that leads you to think that possibly HPA axis dysfunction is the problem for this patient. It's really one of three ways we look at cortisol. We look at the diurnal pattern of cortisol, which most people are familiar with. We look at cortisol metabolites, and then you can also, we look at cortisol to cortisone ratio. You can get all of those from either test. It's just the CAR is added for Dutch Plus. So if you're just getting started, I think it's great to start with the Dutch Complete. It's the easiest for your patient to do. It's, urinary samples only. And then for those kind of specialized patients, you can add the Dutch Plus. Liz, would you add anything to that?
Yeah, no, I think I would agree. It's more, I think the Dutch Plus, it is going to be it's a little more expensive. So when cost is a factor, Dutch Complete does give you a lot of really great information. But I do think having that CAR, having the salivary free cortisol is such a just in the moment, like ability to see that stress signal. And if that really is something that needs to be addressed with fertility outcomes, which is so important. I feel like stress gets poo-pooed as far as like, oh yeah, but it's like, no, it really does impact. If your body is under an immense amount of stress or inflammation and it can barely like deal with its own functions, it's not going to want to allow that blastocyst to implant, right? Like you're not going to want to go through that same process of being able to like conceive successfully. So it really is something worth,
Wonderful. Next question, Liz, maybe you can talk about this more generally about how you integrate DNA tests with Dutch test results.
So number one, I always like to remind both patients and providers when we're looking at functional genomics, this is not full gene sequencing. We are not doing disease genetics. We are doing functional expression of enzymes that everyone is synthesizing. It's just what are the little glitches that could make that enzyme a little wonkier for that person. And I think, when you're looking at, I always tell my patients when I'm doing any genomic review, you could have the worst genes ever, but have pristine environment and lifestyle, and you probably will not have any symptoms, right? And conversely, you could have perfect genetic expression of all these, like optimal expression of all these genes, and have horrible diet, horrible lifestyle, horrible environment, and have all these symptoms, right? And so really looking at the Dutch is a great way to see that expression in real time, to compare, like, for example, I'm going to use COMT, catecholamine O-methyltransferase, as a big example, because we know there is a significant, it's a glitch at the folding of the enzyme. So the one that's most well researched on COMT is how this enzyme will fold. And a valine amino acid at this one location within this very large string, right, of base pairs, that valine creates a very small compact COMT enzyme. Whereas methionine is much bigger as an amino acid and makes a much bulkier enzyme. And so that's going to be a lot slower in its ability to grab methyl groups and donate them to the catechol. But again, depending on your stressors, even if you had a MET-MET variant and were technically a slow type, looking at urine and seeing that 2-hydroxy to 2-methoxy ratio can tell you in real time, how is that gene actually functioning and how well are they actually adapting to being a slow type methylator, because they may actually have pretty good function, right? And do we have to intervene? Not necessarily, unless they're not functioning well, right? So that's how I kind of use the genomics with the Dutch. You can see so many big players genetically or genomically expressing in urine. And then you can determine, oh yeah, I know you have a SNP in the 1B1 and your COMT and your, maybe NQ01 is not working well. And now we're seeing you really are a slow methylator. Your 8-OHCG is high. You're at high risk for oxidative stress. I need to intervene, and this is where and how. Versus, you might even have those SNPs, but you're functioning really well. We don't have to intervene, right? We can just continue with diet and lifestyle. So does that make sense with that? Yeah, sorry.
Yeah, no, I mean, that's great. And it's like you're looking at, when I think about genetics, I think about the patterns you would naturally fall into, right? And then when you add epigenetics as well, but lifestyle factors can help you modify the expression of that. Dutch is looking at the end result. I think genetics look at the potential result or the most likely, statistical result. So it's nice to be able to pull it together to see how genotype and phenotype are connected and how they can be modified. Yeah. Great. The next question was, do you find that people who have a high 5 beta preference have a harder time trying to conceive. I've not seen that personally in practice. And I think when we look at hormone levels and metabolites, you know, probably the easiest example is to think about like androgenicity. Do people get androgenic symptoms, right? And if someone has low or moderately low, or not, maybe let's not even say low normal testosterone in serum, but they have high 5-alpha preference and they have high, more androgenic metabolites, they might feel fine. Whereas if someone was in the high normal for testosterone with high 5-alpha preference, they might experience hirsutism and hair loss and acne. And similarly, again, it's not just the metabolism, it's the total parent hormone and the active metabolite levels. So I just think because, you know, you can have as much diversity in overall hormone value as you can in metabolism. You know, I don't see a trend like that. Do you see a trend, Dr. Bartman?
No, the one trend I do see with strong 5-beta preference is kind of this concern for either chronic low-grade stress or gut issues. You know, and that could impact fertility, right? So it's not that the 5-beta preference is the problem, it's that it's reflecting that something deeper is maybe out of balance. But that's not always the case. 5-alpha, so the SRD5A family of enzymes is strongly regulated by the vagus nerve and by rest and digest versus fight or flight. And I do find that people who are just really well balanced and really just like pretty mellow and do a lot of yoga and meditation tend to be more beta, both in their cortisol preference and in their androgens. And that's totally okay. But for those who are like strong, very high stress, are struggling with a lot of fatigue, a lot of stressors, you know, they're environmentally compromised. And I saw strong beta, I'd be like, oh yeah, there's probably some immune chronic thing going on here that we need to maybe start looking into more thoroughly. Yeah. And the other thing with beta metabolites is that they're used by the gallbladder. They're used for biliary synthesis. So again, that rest and digest, it makes perfect sense. You push more beta when you need that biliary support and that conjugation. So, yeah.
Right. And I think, Jeff, the last question maybe you can answer, which is what tests exists, or maybe what tests do you offer to examine vaginal microbiome health?
I mean, I think there are tests in the market. I'm not aware of any on Rupa or FullScript presently, but I would defer to you two to answer that question in terms of are there tests out there, and who do you like and who are you recommending?
There are a couple on Rupa that I've utilized that are great. The thing that I would look at is the diversity of what's measured. So if you look at Rupa's catalog and you click on samples type is what I would typically do and choose vaginal swab, you'll see all of the ones that come up for that. And then you can take a look at them and compare. I personally like to use a lab that evaluates not just the potentially infectious flora, but actually will type the lactobacillus in the vagina and also look at other microbes that are potentially beneficial. So there are a few available there that you can take a look at. There's a couple that I've used in my practice, and really they've all been very, very helpful. I think I mean, we only have a couple minutes, so I don't know, Kieran, are you going to come back on to close us out, or? I don't need to put anybody on the spot. Here we go.
Yes, I can. If so, we're done. All the questions have been answered. You've
The
all
last
been
one,
amazing.
if we want to cover it, it's not really on the topic here. It was around the fact that lubricants can it's all about vaginal microbiome, really. So
Yeah.
I mean, we can talk about that here if we'd like to, or
You know, it's a couple things on lubricants. I actually did a little bit of work on the vaginal microbiome when I was at Microbiome Labs. There was a study by a clinician, by a researcher, sorry, at university. It presented at one of our conferences. He showed that the types of lubricants used at OB offices in about 20 or 25% of women diminished the vaginal microbiome to a point where it never recovered, like from a single exposure, right? And they were testing the lubricants that they use for the intravaginal ultrasound. And in a large percentage of people, it did diminish the vaginal microbiome, but in many of those cases, it recovered after some time, but in some cases, it never recovered. So we do know that the commercial lubricants can have a really huge impact. One of the things that's been recommended, and I haven't seen data on this, but logically it makes sense. One of the types of things you can use for lubricants from a social perspective is, or for your own personal life, is extra virgin olive oil. It doesn't seem to have any negative effect on the microbes that make up the vaginal microbiome. And it's generally healthy. The components within the phytonutrients are probably good for the vaginal microbiome in many ways. So it's something to consider as well. But we're right on time. So first I want to say,
sorry, just a quick
yeah,
question that came in to follow up is coconut oil. So, and I'll just comment, I think both of those are great for general lubrication, but for fertility specifically, you cannot use those food-based oils during the time of conception. So if you're in your fertile window, you'd want to utilize a lubricant that's fertility safe. There are some available on market. FullScript offers some. So make sure you're finding that, because the specific makeup of it will either allow or make it difficult for sperm to actually swim through and get to the egg. So I would just add that little bit. So sorry.
yeah, that's a really great point. That's a really great point. If you're trying to conceive at that point, that's really important. And one just quick thing on coconut oil, also be careful with that, because those long chain triglycerides that tend to be present in coconut oil are strong antimicrobials. So that can have an antimicrobial effect in the vaginal microbiome. So if you're using one of the two, I'd lean towards the olive oil. But again, be careful if you're trying to conceive. But you all did an amazing job, because we're right on time. So thank you all so much. I think we got a lot of great comments in the chat. Again, as a reminder to everybody that's watching, we will be sending you the recording of this, the PowerPoint, including the Q&A portion as well. We've also copied and pasted the question and answer session, even though it seemed like all questions were addressed. If any of them weren't, we'll make sure to send you an email response as well. Thank you, everybody, for joining us today, and everyone that's watching this on the recording. And thank you so much to the speakers. We really appreciate your time. I think that was a really awesome information packed session. And let's go make babies. So very important for our population. So thank you all so much.
Thanks, Karan.